All right, welcome back. Hope you had a great break. Welcome to our last session of the day. I'm Reto Bertschiger. I'm a surgeon at Dartmouth Hitchcock, and my co-moderator is Melissa Su, who is a pediatric surgeon at Children's Nebraska. Welcome to our session on oncology. Our first speaker will be Nadia Halstead, and she will present on bilateral Wilms tumors, multi-institutional analysis of nephron-sparing surgery at higher volume center. And all the talks are 5 minutes plus 3 minutes for questions.
We may need a different presentation up here.
Yeah.
I think it's... It's S46.
Let me just switch out with Christy.
S46. Perfect. Thank you so much.
But we don't see it yet. There. Perfect.
Okay. Thank you for the opportunity to present our research. AREN 0534 focused on the treatment for patients with multicentric or bilateral Wilms tumor, and they reported a rate of bilateral partial nephrectomy of around 35% for children with bilateral Wilms tumor. However, rates are otherwise variable and sparsely reported. We hypothesize that the rate of bilateral partial nephrectomy at higher volume institutions will be greater than the published rate of 35%. We believe this research is important as we aim to improve outcomes, prioritizing oncologic control with a nephron-sparing approach. We aim to compare the rate of bilateral partial nephrectomy versus unilateral partial nephrectomy with contralateral radical nephrectomy in children with bilateral Wilms tumor. We chose the same study period as the recent COG study for bilateral Wilms tumor to account for variations in practice over time. We hypothesized that the rate of bilateral partial nephrectomy at higher volume institutions would be higher than the published rate of 35% on our AREN 0534. We identified the top 10 enrolling institutions on COG renal tumor banking study, and 5 institutions agreed to participate. We performed a multi-institutional retrospective cross-sectional study from January 2009 to December 2017. We included all children with bilateral Wilms tumor presenting to these institutions during the study period, and we reported data on the index surgery for each kidney. We excluded patients with incomplete data. We estimated a rate of 65% for bilateral partial nephrectomy, and therefore we aim to include at least 50 children based on our power analysis. A total of 51 children were included, 53% were female, and the cohorts were demographically similar. Nearly 90% underwent bilateral partial nephrectomy, and there was no significant difference based on the institution. 12% underwent unilateral partial with unilateral radical nephrectomy, and no children underwent bilateral radical nephrectomy. Most underwent synchronous bilateral surgery under the same laparotomy, and there was no significant difference between the timing of surgery or the stage. Therefore, our takeaway, 88% underwent bilateral partial nephrectomy for bilateral Wilms tumor at higher volume institutions. This was indeed much higher than expected based on what was previously published. And we believe likely this is related to increased experience of the operating surgeons and the multidisciplinary oncology teams at the institutions. We also believe that this provides justification for a follow-up study of children with bilateral Wilms tumor. And we also want to highlight that these are preliminary data. We're currently gathering more granular detail on complications and longer-term outcomes. I want to take a second to thank and acknowledge all of the collaborators across institutions, as well as the patients and families that allow us to do this work. Please feel free to reach out with any questions. Thank you so much.
No, you have to answer questions. Any questions from the audience? While we wait, do you have any like medium-term or long-term outcome as far as renal function and your margin status? Do you know that?
Not renal function, but there was a positive margin rate of 45%. And the event-free survival that we have so far is around 85%, which is similar to what was published in AREN 0534.
And your renal function, do you know that? Anybody had complications on that or not yet?
I don't have that information yet, but that is coming.
Okay,
Yeah.
great. Any questions from the audience?
One other question for you. Do you know if the patients that were captured in your study were originated at those institutions or were transferred in, or do you have that data?
That's a good question. I don't have that information, but yeah, that's interesting.
A more philosophical question, what's a high volume center for these procedures?
Exactly. I mean, I think in this instance, we identified centers that were high enrolling for the original tumor banking study, but yeah, it's not very common. So
Thank you.
yeah, thank you.
Right. Our next presenter is Dr. Peter Ehrlich, presenting Developing a Roadmap for Patient-Centered Outcomes Research. A report from the Patient-Centered
Good
Outcome
afternoon,
Research.
everybody. Thank you.
That's a dangerous t-shirt to wear in Montreal. Just FYI.
Our disclosure is that this was, study was funded from a PCORI grant. So why did I do this research? Well, I saw that we were having the meeting here in Montreal in early May, and I said, aha, the Toronto Maple Leafs are going to be in the playoffs, and the Canadians will be knocked out by then. And I also wanted, most of you know I'm a dual citizen and grew up in Toronto, in case you were wondering. Wanted to know what happened in one of my grade 7 class when somebody showed up on picture day wearing the wrong clothes. And I think that's important. Now, many of you wouldn't believe that, but some of you, Dr. Glick, probably knows that that might be true with me. But the reality of it is I didn't do the work. It was part of a team, and I'm privileged to be part of PSORC and to be here telling you about one of the things that we found very interesting. And we did this because patient-centered outcomes, particularly as defined by the Institute of PCORI, is lacking. And we had a suspicion that what we think and what patients' perspective is very different. And after doing some work, we thought maybe going through the process might be very important as the results. We think this is important because we want to help our patients make informed healthcare decisions. And we do a lot of good research, and if it's not getting translated or people don't know about it, then that's a problem. And we wanted to understand if we went forward how to develop a patient-centered model for it, and that our goal was to develop a roadmap and prioritize future research based on our patient-centered priorities. As mentioned there, when we looked at the patient-centered research and compared the effective questions in cancer for children, there was really only one paper out there, and to date there really is only one paper out there. It was by Tim Lutz. The Children's Oncology Group, which is fantastic, isn't going to do this work. They're focused on traditional chemotherapy, and it's one of the reasons why PSORC started was we knew that there was never going to be questions on surgery that they'd have the time to answer on their priorities. Around the time just before the pandemic, we started to meet with some advocacy groups and some patients and trying to figure out how to do something with patient-centered research. And based on some of the conversations we had, we developed an advocacy group and submitted an award for PSORC, which we were funded to have an engagement award. Sorry. And what we do for today is I'm reporting what we found and some of the information that occurred in preparation for that award, during that award, and afterwards. We adapted a specific framework that was developed by PCORI for identification and prioritization of research areas focused on key input from childhood cancer survivors. This was an iterative process that was done both in sequence and in parallel. There are 4 key components to it. One is education. If you don't understand what patient-centered research is and you don't understand what PCORI will fund, it's probably not going to be helpful to you. So we spent a lot of time doing that. we had, second was a gap analysis. That was actually really easy because it was very specific for and very limited. Then we generated topics, and then we did a value of information analysis that helped us do the prioritization. We spent a lot of time on what PCORI was and what it funds. And at the meeting, we brought in investigators who had PCORI grants and could tell us about it, particularly Dr. Eric Hess, who's from Houston and an adult emergency medicine doctor who had about 4 or 5 PCORI grants, and an advocate who was a mother of a WAGAR patient to help us understand what was going on. We did a lot of pre-conference work, planning, and making sure that we would have a number of different topics. We got a lot of broad input from our advocacy group, physicians, from stakeholders, and conducted some focus groups. Dr. Rich, Dr. Panik, Dr. Reel, Dr. Tracy conducted a survey of 48 solid tumor disease groups and advocacy support groups representing over 1,000 families to get input on what are the things that they felt were important to them to have questions or problems they adjusted when it came to pediatric solid tumor. The gap analysis and systematic review was done by both physicians and stakeholders. And then the value of information analysis was to look at specific questions. Those questions were, what were the difference in health benefits from our question? Would it be a reduction in uncertainty produced by the research? The likelihood these findings can be implemented. This is very important for PCORI. And what was the size of the impacted patient population? That's always a challenge in children because we're basically deal with rounding errors compared to our adult colleagues. And then all of that was put together in a series of questions, and then we underwent peer review and prioritization to produce our research agenda. As I mentioned, the survey was conducted prior to the conference, and the conference took place in October 23. And there was 50 participants, 25 from the medical field, including surgeons, oncologists, the head of the COG, and the number of physicians who have PCORI grants, and 25 that included cancer survivors, their parents, their caregivers, and advocacy group leaders. Some of the key things that were brought to our attention about what might be successful in our grant application was picking a real world problem. And I think this is challenging in our population because a lot of patient choice is parent choice, and that's a little different. Getting people to be engaged early and throughout and not involving stakeholders was brought home as a real problem for future funding. We looked at our literature review, and there was very little, but when we talked about, looked at what surgeons felt were important and what stakeholders wanted, there was a significant disconnect. Stakeholders time and time again brought up questions about surgical skill, expertise, second opinion, pain, healing, communication, how long my child's going to be in hospital. Very little about event-free and overall survival. This was emphasized clearly when we had each group where we picked 4 solid organ tumors and had a parent caregiver give their tops of the top 4 things they'd like to study and what the surgeon would like to study. And one of the striking ones was in looking at limb salvage surgery from the patient perspective, where a number of families and patients said they just wanted them to cut the leg off so they could move on with their life rather than go through multiple operations, and felt that that was very striking. And this came across whether it was renal tumors, liver tumors, or neuroblastoma. We came up with 45 different research topics that covered things including pain, enhanced recovery, communication, and family resources as key issues. when we came down to the end, one of the main things that the group felt and that was voted on was when parents first get the diagnosis, they have no idea what to do, what to ask the surgeon. They wanted to be involved in shared decision making. They felt that getting the second opinion only increased their confidence in the surgeons, whereas the surgeons felt that was something that might decrease their confidence. They wanted to be involved in the important parts of enhanced recovery protocols. And they wanted to develop a method to be involved with patient, parent, and research evaluations. And Dr. Lutz and Dr. Dasgupta have implemented that with all our future PSORC researchers. So we really found and learned a lot from this process, that there's a disconnect and a difference between what surgeons want and what families really think is important. An understanding with their kid with a solid organ tumor diagnosis. We developed some significant partnerships, and this will ultimately, we feel, once we put it together, get to our goal, which will be an overall event-free and overall survival. I think, like anything, we have to be careful. We tried our best not to exclude people. And we hope that we have a broad input from people, but we know that there are groups that we probably didn't reach. The process doesn't define how stakeholders should weigh the criteria to prioritize a set of questions. We made that up as we went along. For example, one of the things is patient-centeredness more important than population impact. And finally, well, we and our group may find this to be really compelling questions. Review teams may not find it compelling enough to fund. So thank you for your time. I appreciate it, and have a good day, and go Leafs.
I think the Leafs went into overtime, so I think we have time for one short question if you want to.
I really applaud you, because that is an insane amount of work that you just described. But I was really surprised by that second opinion bit with the parents. Do you recommend maybe going forward that we just offer that to all families and kind of set it up somehow?
I think it's really important that you, particularly for somebody who may not have 100% expertise because of the internet, they know the names of the people, that you say, did you reach out and say, it's part of it, to say, I'm talking with, Dr. Newman or Dr. Schamberger for neuroblastoma, and they also agree with it. I think coming up there and saying that you do it, I don't think you're going to risk losing the patient. I think it shows that, and I've actually always offered that. For my patients, saying, sometimes I say, I've talked to all my buddies across the country and they all agree with this.
Thank you very much.
All right, have a good one.
Our next speaker is Dr. Srivatsa, who is a surgical oncology research fellow at Nationwide Children, and she's gonna have the two next talks. The first one is age-related variation of presentation and outcomes of pediatric adrenocortical carcinoma, a pediatric surgical oncology research collaborative study.
Thank you so much. My name is Sachi Srivatsa, and I'm the current second-year surgical oncology research fellow at Nationwide Children's. Today, the next two presentations, I'm presenting on behalf of the Pediatric Surgical Oncology Research Collaborative. Thank you for the opportunity. We have no relevant disclosures. Pediatric adrenocortical carcinoma is a rare malignancy, and although we know that it has highly variable presentations and outcomes, most of what we understand comes from small series. Clinically, it's been observed that younger and older patients behave very differently, and we suspected that age at diagnosis plays a major role in determining disease biology, staging, and ultimately prognosis. In other pediatric cancers, age-based staging and risk stratification are already built into treatment algorithms. By identifying how presentation and outcomes for pediatric patients with adrenocortical carcinoma vary by age, we can better predict prognosis at diagnosis, inform surgical aggressiveness, and tailor follow-up schedules. Importantly, we can provide clearer counseling to families and be more intentional in our operative planning. We performed a retrospective review of children aged 18 years and younger diagnosed with adrenocortical carcinoma treated across 22 institutions participating in the Pediatric Surgical Oncology Research Collaborative between 2012 and 2022. Based on the observed bimodal age distribution, we stratified patients into two groups, those under the age of 5 and those that were 5 or older. We collected detailed data on clinical presentation, tumor characteristics, and postoperative outcomes. We included 69 patients. 27 were under the age of 5, and 42 were 5 or older. The median age of the younger cohort was 1.6 years, and 12.9 years for the older cohort. Younger children had a significantly higher prevalence of Li-Fraumeni syndrome, 44% versus 17% in older children. Viralization was the most common presenting symptom across both groups, and the rates did not significantly differ between the cohorts. Tumors in younger patients were significantly smaller, both in size and weight, and vascular invasion was more frequent in older children, 33% versus just 7.4% in younger children. There were no significant differences in surgical approach or retroperitoneal lymph node dissection rates between the two groups. Older children had a significantly higher rate of metastatic disease at presentation, 48% compared to 19% in younger children. Younger children were much more likely to present with stage 1 or 2 disease, and older children were much more likely to have stage 3 or 4 disease. Median follow-up duration significantly differed between the groups, with a median of 60 months for younger children and 35 months for older children. Younger children had better outcomes, with 81% achieving no evidence of disease at last follow-up, compared to just 43% of older children. 19% of younger children were deceased at last follow-up, compared to 38% of the older children. While 5-year overall and event-free survival were not statistically different between the two, the trend still favored younger patients. In our graphs, those less than age 5 are represented by the black line, and those greater than or equal to age 5 by the orange line. 5-year overall survival was 79.6% for younger children versus 56.3% for older children. 5-year event-free survival was 68.3% for younger children and 45.1% for older children. This is one of the largest North American studies of children with adrenocortical carcinoma, matching the enrollment in the COG ARAR 0332 study. Younger children with adrenocortical carcinoma are more likely to present with localized disease and achieve remission following surgery. Older children more commonly have advanced or metastatic disease and worse postoperative outcomes. These data support an age-informed approach to prognostication and help refine how we counsel families. Thank you, and I'm happy to take any questions.
While we wait for somebody to get up, quick question. How many of these children were positive for LFS in the younger patients were actually discovered by screening rather than by diagnosis or symptoms?
So that is a good question, and I don't have the exact numbers for you for that, but it's something. So we specifically looked at whether or not they had Li-Fraumeni and what type of mutations they had, but when exactly they were diagnosed with that in particular, I don't have the answer to.
So my question really ties in with what Reto just said, is that the really high prevalence of Li-Fraumeni in your younger kids, don't you think that maybe could that be skewing your results with the fact that they have longer follow-up and less metastatic disease and that sort of thing? And have you done a subset analysis of those kids?
Yes, and so I definitely do think that there is something to be said about that. It's been seen in other prior small series that the younger children tend to have the TP53 mutation. They tend to have Li-Fraumeni, and this is, obviously this is one of the larger ones, but this has been seen before. And I do think that it's impacting what we're seeing in the long term as well. Like very clearly, we had longer term follow-up for the younger children in comparison to the older. So I do think that there is something to be said about that, but there have been very small trials on the actual molecular characterization of these patients. And it is a very difficult disease to study because of how small the sample size is, even with, international studies. And so it's just a difficult question to answer.
One last question. Do our surgeons follow stage 3 RPLNDs in our series in the PSORC centers or not? Have you seen that? Because that was a big question on the COG trial.
If the next presentation
Okay,
will help answer that question.
All right, so Dr. Srivastava is going to stay up at the podium for the next presentation, which is going to be the surgical approach and outcomes for pediatric adrenocortical carcinoma.
So thank you again for the opportunity to present. We have no relevant disclosures. Surgery is the cornerstone of treatment for adrenocortical carcinoma, but the optimal approach has been the subject of debate. In adults, an adrenalectomy has been the standard due to concerns about capsular rupture, incomplete margins, and peritoneal spread. However, there is minimal direct evidence guiding the choice between open and laparoscopic adrenalectomy. In pediatric adrenal surgery, minimally invasive methods are already widely accepted for benign and select neuroblastic tumors. But for adrenocortical carcinoma, we've historically hesitated. This study is the first large multi-institutional series to directly compare open and minimally invasive outcomes in pediatric adrenocortical carcinoma. We needed to understand, is minimally invasive surgery oncologically safe, and if so, for whom? The primary aim was to assess selection criteria for minimally invasive surgery in children with adrenocortical carcinoma, assess the risk of tumor spillage and recurrence, and guide understanding of nodal sampling. We conducted a retrospective review of children aged 18 and under with adrenocortical carcinoma that were treated at 22 institutions in PSORC from 2012 to 2022. Patients were stratified based on surgical approach, either open or minimally invasive, which included both laparoscopic and robotic-assisted resections. We collected detailed operative data, tumor characteristics, and outcomes, including survival, spillage, and nodal evaluation. 66 patients had complete data for operative approach, 55 in the open cohort, and 11 in the minimally invasive cohort. Tumors resected via the minimally invasive approach were significantly smaller, median size of 4.4 centimeters compared to 9.6 centimeters, and significantly lighter in weight. Intraoperative spillage occurred in 22% of open cases, but in none of the minimally invasive cases, challenging the assumption that open surgery inherently prevents spill. Lymph node sampling in the minimally invasive cohort was poor, with only one surgical case reported as sampling nodes, although none were confirmed pathologically. In the open cohort, 29% of patients underwent lymph node sampling and 20% underwent lymph node dissection. Median follow-up for the open surgery cohort was 55.4 months and was 31.2 months for the minimally invasive cohort. Overall, an event-free survival was not statistically different between the groups. In our graphs, the blue line represents those that underwent a minimally invasive approach, and the orange represents those that underwent the open approach. 5-year overall survival was 87% in the minimally invasive cohort and 67% in the open cohort. 5-year event-free survival was 64% in the minimally invasive cohort and 56% in the open cohort. Although 11 patients underwent lymph node dissection in the open cohort, the distribution of lymph node yield was large and the mean was low, challenging the notion that a true dissection was completed in these cases. The COG ARAR 0332 trial noted that although small, localized tumors can be cured with surgery, retroperitoneal lymph node dissection did not improve outcomes for patients with completely resected large tumors. Importantly, the median number of resected lymph nodes in this study was also less than 5. Although we had hoped to provide more information regarding the utility of lymph node sampling and dissection in pediatric adrenocortical carcinoma, the role continues to remain uncertain. In conclusion, minimally invasive surgery appears to be a safe option for well-selected patients with small, localized tumors and no evidence of nodal or vascular invasion. Contraindications to the minimally invasive approach should include suspicion for nodal or vascular invasion and the uncertainty of achieving an R0 resection. Lymph node assessment was a limitation in the minimally invasive cohort, and the utility of lymph node assessment in pediatric adrenocortical carcinoma remains a subject of debate. Surgeon experience and commitment to oncologic principles must guide case selection and the adoption of minimally invasive surgery for pediatric adrenocortical carcinoma. Thank you so much. I'm happy to take any questions.
open up for any questions. I guess in the meantime, do you think that we should be pushing more for MIS in these patients?
I think so. I think that it's possible based off of what surgeons feel comfortable with. I do think that there was some self-selection occurring in these cases in that people were not necessarily thinking that this was adrenocortical carcinoma when they were going in because of the nature of the tumor itself being small, being well localized without any imaging evidence of nodal or vascular spread. So I think that it can be safe in patients that have very, very clear cut cases, but you really have to be committed to the oncologic principles still and make sure you're doing those things.
One other on that, do you think that advanced techniques like robotics and things like that will start being used more in oncology?
I think so. There have been lots of different studies, and we're using them for all different types of pediatric cancers now. And I think that there are, things that are provided by the robotic approach that haven't been provided in the past in terms of visualization, dissection. And I think that it can be used in oncology as long as we're making sure that the principles that we have always known to be important in oncologic surgery remain to be true.
Hey, very nice talk and study. So you hinted at it a little bit about the selection bias, but did you look at the size of all the tumors and which ones went to minimally invasive and what went to open?
There was a very significant difference in size between those that were selected for in the cohort. So you can see here, so the tumor size was 9.6 in the open median and 4.4 centimeters in the minimally invasive, and tumor weight was drastically different.
The selection bias.
Yes.
So what would be the size that you would feel comfortable recommending for MIS? And you might have to do a ratio from size to patient size too, right? We might not be able to answer that.
I'm not sure that I would be able to answer that, but yeah, it's something to look into. Thank you.
Thank you. Our next speaker is Dr. Williams, who is going to talk to us about social deprivation influences neuroblastoma progression via PA3K, AKT, and mTOR activation.
Yeah. Good afternoon, and thank you for this opportunity to present. We have no disclosures. In 2021, the COG published a study that found poverty to be an independent risk factor for increased risk of relapse and death in children with high-risk neuroblastoma. This study, along with the recent COVID pandemic, sparked our interest to further investigate the role of poverty. We did this research because we hypothesized that non-biologic factors and social stressors have potential genetic consequences, specifically in neuroblastoma pathogenesis. And we wanted to create an animal model that allows a perspective and ethical approach to social determinants of health to further explore the complex molecular pathways involved. Our social deprivation model includes 3 pilot studies, but this study specifically, we looked at food insecurity. In a brief summary, the food insecure group was given varying amounts of food over the course of 4 weeks, and we compared that to a group of mice who had open access to food. And we found a significant increase in tumor size and volume in the food insecure group when compared to the control group. And there was almost double the amount of stress hormones such as corticosterone, as well as norepinephrine and epinephrine, which is not shown here. And we also measured serum VEGF-A, which is a marker of angiogenesis, and found that it was also double the concentration in the food insecure group compared to the control group. And so we wanted to further investigate the moleculisms that were causing that. And we started with the PI3K, AKT, mTOR pathway. And based on a previous study, which characterized this molecular mechanism in neuroblastoma, this study highlighted the multiple downstream proteins that contribute to neuroblastoma's pathogenesis, such as cell proliferation or drug resistance. And in the interesting thing is that in neuroblastoma, studies have noted that there's a lack of elevated P10 or this associated mutation with PI3K. Therefore, it's thought that there's other receptors that are activating this pathway. And so for this study, we focused on the pathway involvement with P53, as this has been shown to be affected by elevated stress hormone. Additionally, we did a previous study where we looked at the alternative NHEJ pathway, and that's a separate pathway that we previously looked at that suggested that high-risk neuroblastoma utilizes a more error-prone DNA repair mechanism, which leads to more chromosomal aberrations and has been found to be a strong predictor of relapse. A general study suggests that there is possibly an indirect link between this pathway and the mTOR pathway through broader cellular response to DNA damage and repair, but to our knowledge, this has not been studied in neuroblastoma or within our social deprivation animal model. So we wanted to focus on why or how this pathway relates to the mTOR pathway. And so we hypothesized that the alternative NHG pathway may be linked to the mTOR pathway due to synergistic effects of p53, leading to DNA damage accumulation and chronic stress, triggering more DNA damage and utilizing this more erroneous DNA repair pathway. We tested this hypothesis in 2 steps. We first did in vitro and then within our model. In vitro study included high-risk neuroblastoma cells, and then we obtained our tissue sample from our food insecure group, did a protein tissue extraction, and then completed our Western blot to investigate the protein expression. And we first confirmed that the effects of the increased concentration of cortisol, as you can see in this box, had led to the inhibition of p53. And we know that that could potentially lead to cell survival due to decrease of apoptosis. And we also noticed that there was an increased level of ligase 3, and this protein is very distinct in the downstream protein for the alternative NHEJ pathway. And so we analyzed this data further with an enrichment plot, and we were comparing our sequencing data with the known set of hallmark genes and observed that when mTORC was downregulated when ligase 3 was inhibited. And we are again suggesting that give us a stronger suggestion that there's a link between these 2 pathways. And then we applied this to our in vivo study in our food insecurity model, and we noticed again similar results. In inhibition of p53, there's this increase in activated mTOR and also an increase in ligase 3. So our findings were parallel to our in vitro study. And so, in summary, we utilized a novel neuroblastoma social deprivation mirroring model to demonstrate that increased stress from food insecurity drives further upregulation of key proteins in an altered PI3K pathway, leading to increased pathogenesis, and that we hope to further investigate the potential treatment targets and potential synergistic effects of utilizing both of these pathways. And then we still hope and believe that our findings can address policy change and leverage for funding for social programs to support this. Thank you.
Paper's open for questions, discussion. As far as mTOR inhibitors, have you looked at everolimus, sirolimus, and if it changes?
Yeah, we have. We wanted to start with some of our cell studies, and then are in the process of doing that in vivo as well. But yes, that is definitely on our radar.
So should you give it to potential patients who come from, like, just translationally?
Yeah, so that's what we're thinking. Would we identify a patient population that would benefit more from this than others? And there's some active clinical trials going on, so we'll follow along with that as well and apply it. Thank you.
Hi, I'm Lenka. I'm the 2B fellow at Iowa, and I actually did my research with Kira Bona, who's she's the medical oncologist who published the paper on deprivation in neuroblastoma. We did a follow-up study looking at GD2 expression, which was where the majority of that, the worst outcomes were primarily in patients who were treated with dinutuximab. And actually, when we looked at actual tissue samples from patients, found no changes in their GD2 expression. So I'm really excited by this. I hope you guys are able to get some tissue banking samples and look in actual human.
Yeah, absolutely. Yeah, we're working. We collect it with all of our patients when we get a chance, and we're just trying to slowly gather information. But thank you for that follow-up.
Thank you.
Thank you.
Thank you very much.
Thank you.
There's some seats in the front rows. If the ones in the back, you want to come and sit down. I know we've been sitting a lot during the last 3 days, but there's some free seats.
All right, next we have Dr. Reinhardt from Children's Hospital of Pittsburgh, presenting upfront versus delayed resection, equivocal in locally advanced malignant rhabdoid tumor of the kidney.
Okay. Good afternoon. My name is Hannah Reinhardt, and I'm a general surgery resident at the University of Pittsburgh. And I'll be presenting our data on malignant rhabdoid tumor of the kidney on behalf of PSORC. We have no relevant disclosures. So malignant rhabdoid tumor of the kidney is rare, and the majority present at an advanced stage. Prognosis is very poor, and poor prognostic factors include younger age, higher stage, and CNS involvement. We did this research to better understand the oncologic effects of different treatment strategies. There is significant heterogeneity in the treatment of patients with MRTK. It has been shown that the tumors tend to be chemosensitive, but delaying surgery for neoadjuvant therapy has not been shown to improve survival. We sought to analyze patients with locally advanced disease and determine the impact of upfront and delayed resection on outcomes. In our study, we collected data on pediatric renal tumors at 24 hospitals over a 22-year period. Of the 3,500 renal tumors, 69 had MRTK on histology, with an overall incidence of 2% in this group. Compared to previous retrospective reviews, ours is the third largest series on this tumor type. The median age in our cohort is 10.1 months. And similar to prior series, the majority of our patients had advanced stage tumors at diagnosis, and overall survival remains poor. Our median follow-up was 45 months, with 10 patients experiencing a recurrence at a median of 2.7 months. Median survival after recurrence is 12 months. Our data demonstrate unadjusted 5-year overall survival of 32% and unadjusted 5-year event-free survival of 29%. Most patients underwent definitive resection, and most received radiation therapy. 98% of patients received chemotherapy at some point during their treatment course. We compared 5-year overall survival in patients by age at diagnosis. Median overall survival was 7 months for patients less than a year old at diagnosis versus median overall survival of 33 months in patients older than 1 year. Older age trends toward improved survival with a hazard ratio of 0.6. In patients with overall stage 2 disease, median survival was not met, and 67% of patients survived to 5 years. Median overall survival was 15 months for patients with stage 3 disease and 11 months for stage 4 disease. Advanced stage trended toward lower likelihood of survival with a hazard ratio of 1.5. We performed a sub-analysis for patients with locally advanced disease to investigate the impact of surgical timing on oncologic outcomes. Patients with local stage 1 and 2 were excluded, and we compared the patients with upfront resection to the patients with delayed tumor resection after chemotherapy. We compared baseline statistics and operative complications between the groups. Given that the study was not randomized, we wanted to ensure that we weren't inadvertently selecting for less invasive and more resectable tumors in the upfront group. And baseline characteristics were balanced between the two groups, including tumor size, tumor weight, and vascular invasion. A limitation is that there could still be unmeasured confounders that we are not aware of. Intraoperative complications were higher in the upfront surgery group, with 3 occurrences of tumor spill and 2 occurrences of blood product transfusion, but the p-value was 0.19. When comparing 5-year overall survival for the two groups, delayed resection trends toward a lower survival with a hazard ratio of 1.5, and median overall survival was 15 months in the neoadjuvant group and greater than 60 months in the upfront surgery group. We performed a sub-analysis of the neoadjuvant group by stratifying patients who received less than 4 cycles of pre-op chemo and those who received 4 or more cycles of neoadjuvant therapy. Median overall survival was 5 months in the short neoadjuvant chemo group versus 33 months in the long neoadjuvant chemo group, with a hazard ratio of 0.7. In summary, patients older than 12 months of age, patients with lower stage disease, and those who had upfront tumor resection trended toward better survival. Our study is limited due to its retrospective nature, and there were no statistical differences from this heterogeneous population at over 20 hospitals. We have reported the third largest series on malignant rhabdoid tumor of the kidney. Most prior series involved clinical data forms, whereas our study involved direct chart review, allowing us to include more granular data. Based on current evidence for locally advanced tumors, the optimal timing of surgery is still unknown and should be decided by a multidisciplinary tumor board in conversation with patients and families. Our data is useful as it can help clinicians give updated prognosis to families, and our surgical timing data could be used in a future meta-analysis on the topic to draw more definitive conclusions. I'd like to thank all of our co-authors who contributed data to this study, and my mentors, Dr. Malik and Dr. Paredes. Thank you for your attention, and I'm happy to take any questions.
Hey, Andrew Murphy from Memphis, Tennessee. I find it fascinating that for many of the other pediatric tumors like Wilms tumor or high-risk neuroblastoma or hepatoblastoma, older age is associated with an inferior prognosis, but for rhabdoid tumor, it's quite the opposite. Do you have any thoughts on why? Is it something to do with germline diagnosis, or does it have to do with the intensity of the treatment regimen, or what's driving that phenomenon?
Yeah, that's a great question. I don't know that I have the best insight into, what the biology or treatment impacts are that are creating that worse prognosis in the younger patients. I'm not sure.
Thanks. Yeah, I mean, I know some of these patients have germline pathogenic variants in SMARCB1, and they also get really strong chemotherapy really early in life. So it's probably one of those two things, but something to think about for the discussion.
Yeah, great point.
Additional
treatment options are limited. The chemo's a little limited, the radiation is limited. And I think more of those kids have the SMARCB1 germination, especially when it's this aggressive.
And in your upfront resection population, how many of these patients were actually thought to have rhabdoid rather than any other kidney tumors?
Yeah, that's a good point. I don't specifically have the data on, some of these patients did have an open biopsy before chemotherapy and resection. I would think a large number of them did, but I don't have the exact data on that. But it was collected, so I could look back for sure.
Thank you. Thank you very much.
Thank you.
Our next paper is from Dr. Halpem, trained tumor-specific T cells for melanoma immunotherapy.
So, thank you for the opportunity to present this work. We have no disclosures. So melanoma is the most common skin cancer in children, and despite advances in therapy, melanoma remains the leading cause of skin cancer death. And our novel method of training tumor-specific T cells results in effective killing of melanoma in a mouse model. This technique may serve as an alternative adoptive immunotherapy for solid tumors. So antigen-primed immunotherapy, which involves stimulating and training a patient's own circulating immune cells with tumor-derived antigens, is an evolving strategy to treat solid tumors. And we developed a novel technique for antigen-primed immunotherapy and used the established B16 melanoma model as a target. So we started by taking B16 melanoma cells, irradiating them, and treating them with BET, JQ1, and C170. We used BET and JQ1, which are MYC-N inhibitors, as our previous work showed that inhibiting MYC makes tumor cells immunogenic, and C170, which is a STING antagonist, was used to target the tumor microenvironment and prevent sustained inflammation that leads to treatment resistance. We also injected B16 melanoma cells into mice and harvested their spleens after a week. We ran ELISA with the antigen-exposed splenocytes in either treated or untreated B16 cells and saw significantly higher levels of interferon gamma production by the splenocytes at both 24 and 48 hours when co-cultured with the treated B16 cells, which suggests that treating the tumor cells makes them immunogenic. So now that we showed that our treated B16 cells are immunogenic, we trained the antigen-exposed splenocytes by co-culturing them for 5 days with the treated tumor cells with GM-CSF and CPG.
Our slides are actually not advancing. We still are on the second slide, and he is on the fifth slide. Sorry about that. So there's a discordance. Perfect. Sorry about that.
Okay, I'll just use this. All right, sounds good. With GM-CSF and CPG, GM-CSF was used to promote the survival, proliferation, and differentiation of myeloid precursors, and CPG, which is synergistic with GM-CSF, was used to directly activate and mature APCs and enhance cytokine secretion. So we then performed flow cytometry to compare the phenotype of our trained cells to naive cells, and we saw significant expansion in CD8 cells with decreased CD4 cells and increased double negative T cells. We also assessed our trained cells using an incucyte assay, and here the tumor cells are dyed red. Green represents caspase 3 and 7, and tumor cell death is seen through bursts of yellow. So we're going to start with the naive splenocytes, and as you can see, the splenocytes are not able to kill the tumor cells as there's the same amount of red in the start and end of the assay. And here you'll see our trained T cells, and you'll see all these bursts of yellow, which indicates the tumor cells are dying. So this is a graphical representation of that incucyte assay. And here you see significantly higher total dead tumor cell area with our trained cells as opposed to antigen exposed and naive cells. So after assessing our cells in vitro, we assessed the ability of our trained T cells to treat tumors in vivo. And we did that by first injecting 100,000 B16 melanoma cells intraperitoneally into black 6 mice, and 1 week later injecting 1.5 million trained T cells intraperitoneally into those same mice. And we monitored at sacrifice at 19 days post-tumor injection. Up top, you see our 5 control mice, and you see large tumor burden in all the mice. And on the bottom, you see our treated mice with significantly less tumors in all the mice, with the 2 mice on the bottom left having no tumors at all. So in conclusion, trained tumor-specific T cells are a promising approach for adoptive cellular immunotherapy for melanoma, and further work is needed in isolating and proliferating our effector T cells before this treatment can be translated to patients. I want to thank our whole team, especially my mentor, Dr. Sandler, for help with this project, and I'd be happy to take any questions.
Afternoon, Lindsay Talbot, St. Jude. It's really interesting, and I love the immune competent setting that you're using, and think it's really important. Can you elaborate a little bit more about the rationale behind specifically supporting your myeloid cells in the training paradigm that you're using for the T cells? And can you clarify whether or not the trained cells that you injected, were they whole fraction splenocytes, or were they comprised of the full T cell and myeloid subpopulation?
Thank you. So we injected all the cells from the treated splenocytes, the trained splenocytes. Most of the cells actually ended up being T cells at the end. It went from around 25% of CD3 positive cells in the naive to over 70% in the trained cells. So we're calling them trained T cells, but they were really in this specific experiment trained splenocytes. We are working on isolating the cells and kind of evaluating them through incucyte assay to see which ones are effective, and we believe that just injecting the T cells will be our eventual final treatment. And in terms of maintaining the cells during that process, we use some antibiotics, we use IL-2. We're looking at optimizing our actual media that we use, but currently we use IL-2. We're looking at IL-7 and IL-15 as well, but still optimizing that process.
Hi, sorry I didn't announce my name last time. Tammy Westmoreland from Nemours. So the B16 cell line, that's a mouse-derived melanoma cell line. So are you going to do the studies in the human-derived melanoma cell line, A375?
So thank you for that question. We started with this model. We actually started with this product through a neuroblastoma model, both in human cells, like running it in vitro, as well as in mouse neuroblastoma in vivo. And then we transitioned to B16 because we know it's a very difficult to treat model. And then we're further working on possibly evaluating that as well.
And then just the second question, you used a black 6 mouse. that has a full complement immune system. Have you considered testing your study in an NCR nude mouse, which is athymic?
We have not tried that yet, but that's something that we could look at in the future.
Great. Thank you.
Thank you.
Next, we have Dr. Christine Forkham from Children's Hospital of Colorado, presenting the impact of diagnostic biopsy technique on the adequacy of biologic data required to risk stratify patients with non-high-risk neuroblastoma.
Thank you for the opportunity to present. Let's see if this is working.
Press on the green button. The big one, the big one. Yep. The slides are not advancing.
There we go. Great, thank you. So many of us know that neuroblastoma is the most common extracranial solid tumor of childhood, making up 8 to 10% of all childhood cancer diagnoses. Especially important for neuroblastoma is gaining adequate diagnostic tissue sampling to confirm the diagnosis, to help risk stratify patients, to come up with treatment planning for the patient, and also figure out trial eligibility. Adequate tissue is needed to obtain tumor biologic data specifically, including tumor histology, MYC gene status, DNA index, and to be able to perform segmental chromosome aberration analyses. What we noted was there was a significant shift in solid tumor biopsy techniques from the traditional open biopsy to more minimally invasive techniques such as laparoscopic or thoracoscopic biopsy, as well as percutaneous biopsy, often performed by our interventional radiology colleagues. So the goal of this study was to assess the effectiveness of less invasive biopsy techniques in the Children's Oncology Group AMBL 1232 study. The inclusion criteria were patients less than 18 months of age. Those were enrolled in ANBL 1232 from 2014 to 2023. And ANBL 1232 was utilizing response and biology-based risk factors to guide therapy in patients with non-high-risk neuroblastoma. We included patients in Group B, which were patients with L2 tumors, as well as Group C patients who had MS disease. Tumor biopsy in the study was mandatory for Group B patients at diagnosis and for those Group C patients who are asymptomatic. We excluded patients in the study who did not have a complete surgical checklist, those who underwent upfront resection, and those within the Group C with MS disease who are non-biopsied, likely due that they were too sick to undergo biopsy and went treatment upfront. Our primary outcome was to look to see if they have obtained satisfactory biologic data, which we defined as adequate tissue to perform tumor histology, MYC gene status, DNA index, and again, segmental chromosome aberration analysis. We also collected data on biopsy technique and primary tumor site. When we looked at the COG AMBL 1232 study, we assessed 160 patients for eligibility, excluded 32 based on the criteria I just went over, and 128 met inclusion criteria. Ultimately having 60 patients in our Group B and 68 patients within Group C. And when we looked at the results for adequacy of biologic data for those 128 patients, we looked at it for study group, primary tumor site, as well as biopsy technique. And what we found was there was no difference between Group B and Group C patients when you looked at satisfactory versus unsatisfactory biologic data. Similarly, there was no difference based on primary tumor site. When we looked at biopsy technique, there was a statistically significant difference in obtaining satisfactory versus unsatisfactory biologic data. Specifically, patients who underwent percutaneous biopsy had a higher percentage of unsatisfactory biologic data. We also wanted to look at procedural complications, and overall, those were rare across the cohort, and we found no difference between open, laparoscopic, thoracoscopic, or percutaneous biopsy. We do want to highlight a few limitations to this study in that AMBL 1232 include only non-high-risk neuroblastoma patients. And then as part of that study, we have no granular data about volume of tissue obtained, how it was obtained, the gauge of the needle, how many passes.
And then we also want to acknowledge that there could have been possible changes in practice or proficiency with percutaneous biopsy over time. So in conclusion, children less than 18 months of age who with non-high-risk neuroblastoma and COG AMBL 1232 who underwent percutaneous biopsy had lower rates of satisfactory biologic data. We would like to talk about improving the efficacy of percutaneous biopsy techniques in neuroblastoma because we know adequate tissue is crucial for all the things we spoke about before. This includes discussing with your interventional radiology colleagues the number of cores needed, having pathology present, and having ongoing multidisciplinary discussions, especially for those children who are young, like as was in this study. And then we'd also like to have ongoing considerations for developing alternative assays to allow better utilization of biopsy samples that we are able to obtain. I'd like to thank my Children's Oncology Group Young Investigator Mentors Holly Meany and Dave Lahl, as well as the AMBL 1232 study leads. Thank you again for the opportunity to present, and I'm happy to take any questions.
Just a question. What do you think the best way to get your interventional radiologists on board with getting adequate biopsies? Is that something that I've struggled with at my institution? We actually have a meeting coming up to discuss exactly what we need with our interventional radiologists.
I think is understanding kind of what they feel comfortable with, what age cutoff, what the actual tumor looks like, the location, and then talking about maybe having the pathologist present too, so it's kind of ongoing feedback in the procedure to make sure they're gaining adequate tissue. We struggle a little bit with some of those younger patients for size and the number of the cores needed, but I think as we develop new trials, as was mentioned on Wednesday, having a set guidelines of what is actually needed to obtain satisfactory biologic data.
Do you think with that 80% unsatisfactory data, unsatisfactory biopsies with the percutaneous biopsies, we should move away from that, or do you think education is enough?
I don't think we should move away from it because we've seen success of using percutaneous biopsies in other extracranial solid tumors. I think it's this ongoing multidisciplinary discussion of how we can become more proficient in performing them, because as you can see, it is a safe alternative to doing open biopsy. And for this study in particular, there are numerous assays that were sent, including fresh and frozen specimens as well. So thinking about what we're using when we gain tissue for these studies.
Hi, Rami Jamshidi from Phoenix. Thanks for asking a really bedside relevant question. It's wonderful. I think for a lot of us in our centers, the clinical practice has moved in this direction, but without certainty that it's the right thing to do or okay thing to do. So you already said the thing that probably many of us went shucks about, which is volume of tissue obtained or number of passes, so we set that standard. Do you have two questions? One is, within the data set you've obtained or your access to the information, are you able to go back and fill that in or find that data? And the second question is, when are you going to get us the answer for over 18 months? And can you get the volume for satisfactory versus unsatisfactory at that time?
Right. We don't have that data, and that was one of the limitations that we highlighted, and we wish we did, to try to give some sort of guidance on what you need for obtaining biologic data. And hopefully with setting up some of the new trials, especially the high-risk trial, of having guidelines and protocols and then having that document in the CRFs is really important for ongoing studies. It's a really important question. Thank you.
As you mentioned it, I think having the pathologist there might be key, or even the surgeon who does the translation between IR and the pathologist. I think I find that very helpful.
I think that's helpful too. Thank you so much.
Thank you. Our next presenter is Dr. Jeremy Jen from Memorial Sloan Kettering, talking about the management of tyrosine kinase inhibitor-related pneumothorax in patients with metastatic sarcoma.
Okay. It's a green button?
The big green button advances.
Yeah, this one. Let me just double check. Okay. Good afternoon. Welcome. I would like to thank the program committee for the opportunity to present our research. I will be talking about management of tyrosine kinase inhibitor-related pneumothorax in patients with metastatic sarcoma. These are our disclosures. So osteosarcoma and synovial sarcoma are two of the most common pediatric bone and soft tissue sarcomas, and the lungs are the most common site of metastasis for both. Tyrosine kinase inhibitors are a growing class of agents used to control systemic disease in these patients. However, pneumothoraces are a well-described complication of TKI therapy that can cause patients to stop treatment and affect their disease course. There's little literature on the management of such pneumothoraces. TKI therapy has also known adverse effects on wound healing, potentially impacting recovery. Therefore, the purpose of the study is to describe the management of pneumothoraces in sarcoma patients treated with tyrosine kinase inhibitors. So our study was a single-center retrospective case series. We reviewed patient charts and imaging to identify patients with a diagnosis of osteosarcoma or synovial sarcoma between the ages of 50 and 39 who received TKI therapy. We excluded all patients with postoperative or iatrogenic pneumothoraces. So with this, we identified 88 patients with osteosarcoma or synovial sarcoma who were treated with TKI therapy. Of these, 15 patients developed spontaneous pneumothoraces during the study period. In 5 patients, the pneumothorax was not related to the TKI therapy. Therefore, in total, we had 10 patients, or 11%, who had a pneumothorax determined to be related to the TKI. So these are the patient characteristics for our 10 patients. The median age is 22. Most of our patients had a diagnosis of synovial sarcoma. And you can see 4 patients had a single TKI course that was continuous. 2 had a single TKI course that was interrupted with a gap. And then 4 patients had multiple TKI courses. 50% of our patients developed recurrent pneumothoraces with numbers of recurrence ranging between 1 and 4. This graph shows the timeline of each patient's pneumothorax along with their TKI therapy. The inverted triangles represent pneumothoraxes on treatment. Colored lines represent the duration of therapy with different colors showing different TKI treatments. So the break in the graph illustrates one patient who had a protracted gap between TKI therapy that subsequently developed a pneumothorax once treatment was restarted. So this flow chart shows the management of initial pneumothorax. Out of the 10 patients, 4 patients were initially treated with observation and 6 received a chest tube. 7 of the 10 patients had resolution with this initial treatment. 1 patient required a Heimlich valve, 1 patient got a thoracotomy for a bronchopleural fistula, and then 1 patient died due to unrelated causes. Following initial pneumothorax, 5 patients had recurrence, with median time to recurrence being 6 months. Out of those 5 patients, 4 were treated with observation and 1 was treated with a chest tube. 4 of those 5 patients had pneumothorax resolution. Again, 1 died due to unrelated causes. 2 of those 4 resolved patients went on to not develop any more recurrences, but the other 2 went on to develop multiple recurrences requiring invasive interventions, including chest tube placement, bedside or VATS pleurodesis, Heimlich valve placement, and wedge resection. Of note, both of those patients had recurrences even after pleurodesis. This table summarizes the impact of pneumothorax on continuation of TKI systemic therapy. All 10 patients did eventually stop TKI therapy. 4 of them discontinued specifically due to pneumothorax-related reasons, while the other 6 discontinued due to medication toxicity, disease progression, or death. In conclusion, management of these patients is complex due to oncologic factors and patient goals, with TKI therapy continued in several patients with recurrent pneumothoraces due to therapeutic response to TKIs and lack of other treatment options. Our studies show that pneumothorax observation or chest tube placement resolve most initial and recurrent pneumothoraces, but this can be a treatment-limiting complication for many of these patients. In addition, multiply recurrent or complex presentations may require earlier surgical intervention and cessation of TKI therapy. Though surgical intervention such as pleurodesis, did not seem to prevent future recurrences. Limitation to our study include the single-center retrospective study design and the overall small number of patients. Future goals include assessing factors associated with development of a pneumothorax while on TKI therapy, as well as optimization of care to identify strategies to keep patients on their intended oncologic treatment. Thank you. I'm happy to answer any questions.
Hey, great talk. Lindsay Talbot, St. Jude again. This is such a challenging situation. We've recently had one of these cases too, and it just is really tough. I have 2 questions. What was what made you determine that the ones that you chose to analyze were definitely related to TKI therapy, other than just proximity to treatment or being on TKIs? And sort of related to that, did you look at like the distribution of the lesions in the lungs? So sometimes we have these patients with very peripheral lesions that just keep popping them open, and it may or may not actually be related to drug. So I just wondered your thoughts on those.
Yeah, exactly. And that's sort of one of the limitations of this study, which is that we couldn't look at those risk factors, including like metastases. I mean, all of our patients had lung metastases. That's actually a current study that we're working on, identifying those lesions, especially using like machine learning and trying to identify which factors, radiomics, and which lesions and what contributing, what it can contribute to the pneumothorax. But yes, in our case, it was really mainly only timing. So if those pneumothorax developed on the TKI therapy.
Did previous chest surgery change anything, or you excluded the ones who had a biopsy or a resection?
We didn't exclude patients who had a previous biopsy or resection because there were patients both with and without that would develop pneumothoraces and sometimes contralateral as well. So yeah, we didn't necessarily exclude those because there were plenty of patients with TKI therapy that didn't develop pneumothorax despite that.
Thank you. Any other questions? Thank you.
Thank you.
Next presenter is Dr. Remen from Yale, presenting the use of nicotinic acid to widen the therapeutic index of NAMPT inhibitor FK866 in neuroblastoma.
Thank you for the introduction. Good evening, everyone. My name is Shayan Rahman, and I am a general surgery resident at Yale. Thank you for the opportunity to share our work. As mentioned earlier, neuroblastoma is the most common pediatric extracranial tumor, and it is marked by clinical heterogeneity, ranging from spontaneous regression to advanced presentation and progression. Outcomes are particularly poor among those in the high-risk group and those with recurrent disease. Neuroblastoma accounts for about 7% of all childhood cancer diagnoses and about 15% of childhood cancer deaths. Current multimodal therapies include those listed here. Poor outcomes in high-risk and recurrent cases, despite current therapies, warrant exploration of additional therapeutic options. Our lab is interested in exploiting a well-described metabolic shift that occurs within cancer cells known as the Warburg effect. The Warburg effect was first described in the 1920s and is defined by a shift away from the TCA or Krebs cycle despite the presence of oxygen, a phenomenon known as aerobic glycolysis, leading to conversion of pyruvate to lactate. This process is nicotine adenine dinucleotide, or NAD, dependent, and carries benefits to tumor cells such as rapid ATP synthesis. FK866 is an inhibitor of the rate-limiting enzyme in the nicotinamide, or NAM, salvage pathway of NAD synthesis. The clinical translation of NAMPT inhibitors has been halted by dose-limiting toxicities due to off-target effects such as thrombocytopenia, GI upset, and retinal toxicity in rats. This brings up the idea of a therapeutic index, or a dosing window that maximizes the intended effect on target cells while minimizing unwanted side effects on off-target cells. In this case, the target is tumor cells, and off-target refers to normal cells. We were interested in finding a biomarker that could be used to guide how we utilize NAMPT inhibitors in neuroblastoma. Nicotinate phosphoribosyl transferase, or NAPERT, is the rate-limiting enzyme in the Price-Handler pathway of NAD synthesis. This takes nicotinic acid, or NA, and converts it to NAD. It is known that some tumors exhibit hypermethylation at the promoter region of the NAPERT gene, leading to silencing of gene expression and protein loss. In NAPERT-negative tumors, inhibition of NAMPT with FK866 would then lead to both pathways being unable to generate NAD, therefore generating some sort of synthetic lethality. In contrast, the normal cells, or non-tumor cells that have intact NAPERT, could utilize nicotinic acid to maintain their NAD pool, thereby mitigating the side effects of NAMPT inhibition and widening that therapeutic index, or that space between the curves I showed earlier. So how often is NAPERT actually silenced in neuroblastoma specifically? Using the Broad Institute's Cancer Dependency Map, or DEP map, we found that neuroblastoma had a combination of one of the highest methylation fractions and lowest protein abundances among a number of cancer types, suggesting frequent silencing on the cell line level. But that's just cell lines. We confirmed these results on the patient level by staining a tumor microarray, or TMA, that we obtained from St. Jude's, containing cores from 30 patients with neuroblastoma. Over 70% of patients were found to have NAPERT-negative tumors. Next, we aim to evaluate the effect of NAMT inhibition with and without nicotinic acid supplementation in our models. We utilize 4 human neuroblastoma cell lines to perform growth development assays. On the x-axis, we show rising concentration of FK866. On the y-axis is cell survival. On the left, we have our 2 NAPERT-negative cell lines, and we see that with or without nicotinic acid, the effect is the same, cell death with rising concentrations of FK866. On the right, we have our 2 NAPERT-positive cell lines, which we are using to model quote-unquote normal cells. As we hypothesize, these cells are sensitive to FK866 without nicotinic acid supplementation and are rescued with nicotinic acid supplementation. This is the same data, but on a singular plot. These tumor cells were sensitive to NAMT inhibition, and only the NAPERT-positive cell lines in bold, which we were using to model off-target or normal cells, were rescued by nicotinic acid. In conclusion, neuroblastoma is sensitive to NAMT inhibition in vitro. Most neuroblastoma tumors in our samples were NAPERT-negative. NAMT inhibitor plus NA supplementation to target NAPERT-negative neuroblastoma may be a viable strategy for minimizing the dose-limiting toxicities traditionally associated with NAMT inhibitors. Thank you to our collaborators and my mentors. I'd be happy to take any questions.
Open to any questions?
Very nice talk. So in your cell lines that you showed for neuroblastoma, on the right with the positive, with the NAMT, they're recurrent cell lines. So SKNAS and SKBE2 are recurrent lines. And the lines on the left where they were not elevated, one's a bone marrow metastasis and one's a brain metastasis.
Correct.
So have you noticed a difference in expression as opposed to, say, a primary neuroblastoma, as opposed to recurrent or metastases?
We haven't looked at that question specifically, but on the topic of looking a little bit more deeply into our cell lines, I thought one thing to look at that would be interesting was NMIC status. In theory, higher NMIC status would introduce some replication stress and would make a cell or that subtype of tumor a little bit more dependent on their NAD pool to continuously replicate. Interestingly, the lowest IC50 or inhibitory concentration that we had was in a known high amplified NMIC cell line. But to your question, that would be a good question to look into in the future. But we did purposefully include some recurrent cell lines and we'd like to have a variety of cell lines moving forward. But I think if we're targeting high risk and relapse, it was particularly important that we included recurrent cell lines.
Do you plan to move into a mouse model in vivo?
Yeah, so I've been working on that. The next steps for this study are generating some isogenic cell lines, so knockouts and overexpression models, and that's what I've been working on now. I finally gotten our animal models to work, and this is a little pilot study that I did recently in the past few weeks where we were able to establish a xenograft model of SKNAS, and then we were able to use an NAD assay from Promega where we grew out the tumors in vivo and then treated the mice with NAMT inhibitor and then sacrificed the mice, harvested the tumor. And the kit allows us to actually look at the concentration of NAD in our sample. And we were able to show, at least in this very small pilot, this is 2 mice. So hopefully we'll have a follow-up with more data. But you can see a decrease in NAD with NAMT inhibitor treatment.
And do you think you can rescue these mice with your nicotinic acid, or the side effect profile of your inhibitors will just kill them?
I haven't done that yet in neuroblastoma, but I'm hoping to present our data in rhabdomyosarcoma at AAP in the fall. But we have seen that in other models.
Great. Thank you very much.
Thank you.
And our last presentation is by Dr. Joseph Mazar from Nemours Children's. He's going to present on the in vivo distal modeling of the Zika viral therapy of high-risk neuroblastoma requires permissive host cells at the point of contact for patient tumor elimination.
Okay, I guess I'm the cleanup crew. Okay, nothing to disclose. Let's see, how does this rotate?
It's the green button, the big green button.
Big green? Okay. Okay, my name is Joseph Mazar. I'm a research scientist at Nemours Children's Hospital in Orlando, Florida. And this work's been a project we've been working on for a number of years now in the lab of Tamara Westmoreland. So let's get to it. So a little bit of background on neuroblastoma, not that anyone really needs it. It seems that a lot of people beat me to the punch. But neuroblastoma is a cancer that forms from progenitor nerve cells called neuroblasts. And what we have here is neuroblasts are immature nerve cells that typically should develop into working nerve cells, but in the case of neuroblastoma, they develop into cancers instead. And that's actually been rather crucial to our model. So neuroblastoma, again, I'll be redundant, accounts for about 8 to 10% of all malignancies in children, and it's the most common solid extracranial malignancy of children worldwide. It also accounts for a disproportionate 15% of cancer-related deaths. Now, Zika virus, which a little bit out of left field, it's a member of the virus family Flaviviridae. So these are messenger RNA-like virus genomes, rather small. But actually, they don't tend to mutate very much. They're rather stable genomes despite 70, 80 years of strain isolation. So most cases of Zika, however, are asymptomatic. Only about 20% actually have any symptoms at all. Most of them are mild and self-limiting. It's an acute infection, but actually rather mild, not chronic. So our work over the last number of years now has shown both in vitro and vivo that we can use those oncolytics in neuroblastoma and actually a number of different developmental cancers as well. And we've done that again, both in vitro and vitro published. But the bigger problem now is that most of the work that we've done has been local. We've done all kinds of models, pre-treatment, post-treatment, recurrent, chemo-resistant. But the really big problem is half of all solid tumors are metastatic. And that's where an awful lot of the mortality comes from. So it's great if we can eliminate local tumors with no side effects. But the bottom line is if we can't eliminate metastatic, then that's a huge gap in the therapy. So we were asking the question, well, how can we treat metastatic models, given that our approach typically is to introduce Zika locally to a tumor or tumor bed? We were asking this question and thought, well, okay, wait a minute. The native model for introduction of Zika into a human host is a mosquito. And how do they do that? They basically bite you. They introduce it into the dermis, which can often enter into the bloodstream. So the model for how Zika actually infects permissive hosts is a rather simple one. Attaches to a host that's a permissive cell, attaches, penetrates. You have viral synthesis, viral assembly, and viral release, and then it just releases typically into the bloodstream, finds another permissive cell, and continues the process. So we asked ourselves, okay, well, if the model for native introduction of Zika is just a simple dermal induction, could we do that as a mouse model and also affect potentially metastatic or distant tumors? So we started the model very simply. We introduced a tumor to one flank, introduced Zika to the other, and then just watched and waited to see what would happen. Can Zika translocate from a dermal injection to a tumor that's only, say, 1 centimeter away? And the result was absolutely not. Zero penetrance whatsoever. This is terrible. So when we introduce locally, we can eliminate the tumors fast and quick, usually about 7 to 10 days. Most of them we get no recurrence. But unfortunately, when we introduce it just a little bit far off the tumor, we get nothing at all. So unfortunately, every single mouse in this model died. We actually had no loss of tumor mass whatsoever. They are asymptomatic, so that's good. But the reality is that this is not an effective model. So unfortunately, you cannot simply introduce Zika into a host, hope it'll find its target, and do all of the work for you. So I stepped back and said, okay, well, obviously that's not going to work. But we do know when we introduce locally, we get a great effect. We can eliminate tumors 90% of the time, and I'd say 80-90% of the time, we don't even get recurrence. So what if we tried introducing to a tumor, which we know is permissive, could one tumor be used to treat others? And so we tried a different model. What happens if we introduce tumors to both flanks? And then we introduce Zika into only one of them. And we watch and wait and see what happens. And what we found, Actually, yes, that does work. So when we don't treat either one, either tumor individually can be fatal. And so all of them that were untreated, regardless of which flank, were fatal. And in the orange line, you can see when we introduce to the right flank, we can eliminate those tumors pretty much 100% of the time. But when we introduce to the right flank, the left flank actually has therapeutic effect. So we found is actually all of them had some therapeutic effect. In other words, we got loss of tumor mass in every single one of them. But about 2/3 of them, we would lose mass and they would never recover. So we could eliminate both tumors with only one injection. And so here was actually the survival study data. And so what this suggested is that if you can inject Zika into a permissive tumor, you can weaponize one tumor to kill the others. So our conclusions, well, both pretreatment and recurrent neuroblastomas are responsive. That doesn't seem to matter. MYC-N amplified or not didn't matter. Chemo-resistant didn't matter. Recurrent didn't matter. The virus doesn't really seem to care. Those characteristics have really nothing to do with penetrance. It comes down to one of the reasons that it is effective, which is that neuroblastomas derive from neuroblasts, and neuroblasts as developing cells are type 1 interferon defective. And since they have no antiviral response whatsoever, the virus can infect those tumors, completely eliminate them, and the surrounding tissue doesn't even have an inflammation response. We've done this in athymic mice, BLAK6 wild-type mice. We've even done it in NSG mice, so T-cell, B-cell, macrophage, dendritic cell, and natural killer defective. And so what we find is that really all you need is an active type 1 interferon response, and you can self-eliminate the virus in about 10 to 12 days. We've also done shedding studies and found that in about 7 to 10 days, the viral load decreases in pretty much every organ of the body from 10 to the 6th in the tumor to 10 to the 1. So the host is very easily able to eliminate it with basically no side effects whatsoever. Now, the survival advantage when we do this with a single injection is roughly about 90%, but the truth is we can inject more than once. We just wanted to see how robust can this actually be. So when we locally inject, 90% of the time we can eliminate. If we come back later, we can often increase that to 100. But you really have to introduce into a permissive site. See, type 1 interferon is rather effective against Zika, and so when you introduce anywhere other than to a permissive site, the virus gets eliminated. You have no therapeutic effect whatsoever. However, when you do introduce to one tumor, what we did discover, which was nice and surprising, is that one tumor can actually act as a factory, produce virus, and then release that into the blood and introduce it to other tumors, which also are therapeutic. So, other directions? Well, it sure would be nice to know more about that mechanism of action. We've been working on next-gen sequencing for quite a while now, and are narrowing down to specific genes that we find are responsible for this sensitivity, not just type 1 interferon. In addition, screen other models, orthotopic and PDX. We actually have orthotopics running now. And obviously other cancers. We found a number of different developmental cancers, such as hepatoblastoma, nephroblastoma. They're all sensitive and basically for the same reason. But there actually are a few adult cancers that we are looking into as well. Naturally, this is a team effort. This work was done in the lab of Tamara Westmoreland, and I'll take questions.
Great job. Afternoon. Lindsay Talbot again, St. Jude. So just challenging a little bit.
Please.
This smacks to me of endogenous immune activation and antigen presentation on the same side that you're looking at, and then migration of activated endogenous immune cells to the other sites of tumor. And so I wondered, have you looked at the draining lymph nodes for your flank that you injected versus the one that you did not, or the microenvironment in the two tumors to assess which immune cells are there and whether they've been activated?
Sure. So we haven't done that yet. But actually, like I said, we've actually done this in NSG mice. The issue is the tumors get eliminated, but unfortunately, as the tumors literally liquefy, they will eventually drain into the blood, and without macrophages and dendritic cells to clear that up, it can be toxic. Basically, it's a tumor lysis syndrome effect. But most of this work we do in athymics. We've also done it in wild-type BLAK6s. So there was work that was published in 2017 at UNC Chapel Hill. And what they showed was that in type 1 interferon receptor knockout mice, all mice had a fatal response to Zika virus. So all you had to do in a completely wild-type immune system mouse was inhibit the ability of type 1 interferon to interact and activate signal through type 1 alpha and beta receptor. And the mice had basically no response to Zika whatsoever, so it was fatal. But again, when we do this model in completely immune-compromised mice that have type 1, they survive 100% of the time.
Yeah, I have to agree with her comment. It sounds a lot like an abscopal effect, like you see with radiation therapy, or even with our experience with oncolytic herpes simplex virus. So I wonder if you've taken the tumors and done any sort of assessment of where, if the virus is actually there. Have you done plaque assays? Do you actually know that the virus is multiplying and
We're actually in the middle of doing that
yeah,
right now.
and
I got the
increasing
histology running for various immune factor cells. Yeah, but I mean, I'd love any ideas. So,
fascinating study, Bob Schamberger from Boston Children's. One question, in neuroblastoma, metastatic sites in the bone marrow seem to be particularly resistant to treatment. Does a secondary treatment affect your metastatic disease if it's in the bone?
So anytime we've done secondary with Zika, so more than one round, we've done as many as 4 rounds. Largely what we found is that as opposed to the idea that the virus travels very well within solid tissue, that's actually not true. It doesn't. So for example, when we have nodular tumors, we can eliminate one tumor, but local ones that are literally right next door have no therapeutic effect, and you have to go back in. But we don't see any immune response from the host, even in wild-type mice. So normally speaking, Zika is eliminated in about 8 to 12 days, asymptomatically. And so you never even get to the antibody response, typically. But in bone marrow, I imagine, again, it's just access. So if blood vessels have good access to that bone marrow, Zika will probably find its way there, because it is a bloodborne pathogen to begin with. So that's its native environment.
But you haven't tried that yet?
No, I haven't. So I'd love great new models. So we've done dozens of different models and different sorts at this point to try to determine what really is the extent of its efficacy and robustness.
So it's my understanding Zika virus is a neurotoxic virus, right?
Absolutely.
Did you look at the brain of these animals?
Yep. So we've also done intracranial studies. We spent almost a year getting ourselves ready to do them. And what we find with Zika is in the brain, it's actually very dangerous. So you have to be very careful. What's interesting is that studies have been done before of actually introducing Zika into the brain, and they can see toxicity with levels of 10 to the 4, 10 to the 5, whereas we introduce levels in the midsection at 10 to the 6 or 10 to the 7, and we see no toxicity whatsoever. So what's interesting is the fact that there's some literature that suggests that it actually can pass to the blood through the blood-brain barrier. But if that were the case, I would imagine with doses of 10 to the 7, we'd see some toxicity in our mice as well, and we simply don't. So somehow, for whatever reason, either the dose necessary for pathogenesis is not significant enough passing through the blood-brain barrier, or it largely just doesn't do it at all. But when you introduce directly with wild type, so we're using MR766, which is the index strain. So this is the virus that was isolated in 1947 in Uganda. That's the name where it got Zika. And it's actually a significantly more robust form of the virus. We're looking at attenuated strains to introduce in the brain, and we've worked on a couple so far which are kind of the opposite, where we introduce them, we see absolutely no toxicity whatsoever, but not much therapeutic benefit. So right now we're looking for that Goldilocks zone, where we have one attenuated strain that basically does almost nothing, and mind you, its plaques are small and its titers are small, and another that's very aggressive and effective. So in the midsection, that seems to work great, and especially because the tumors are very large and robust. When we use attenuated, we see barely a bump in loss of tumor mass and almost no shedding. But when we use a more aggressive one, we can wipe them out in 7 to 10 days, no recurrence, and they're asymptomatic. So,
thank you.
Thank you very much.
Thank you for all of our presenters. A reminder to all faculty scoring presentations, please submit your scores now. And as a reminder to everybody, the President cocktail reception starts at 6 o'clock in Parc Mont Royal, followed by the President's dinner, et cetera, et cetera.